We are very grateful and thankful that Dr. Wilcox is presenting this morning. She was a school psychologist for 8 years before completing her PsyD in school psychology in 2009. She completed postdoctoral training in clinical neuropsychology, where she practiced as a licensed psychologist until joining the Workland School of Education at the University of Calgary. Dr. Wilcox is a registered psychologist in Alberta and a nationally certified school psychologist. Thank you, Dr. Wilcox.
Yeah, thank you, Julian. I'm happy to be here today to go over the first part of comprehensive behavioral intervention for tics. Get my slides to go here. So the information from this presentation is based on several books about CBIT, as well as the CBIT training that I did. It's important, I want to note that these sessions are not official CBIT training. So if you want to be CBIT certified, I have the website there about the official training. The next one I saw is going to be in Pittsburgh. So it's a little bit of a distance, but it is a really fabulous training. So if you're interested in becoming a CBIT certified therapist, there's some more information there for you. All right, so today we're going to talk about the rationale for CBIT. So why this is the first line of treatment, who it's good for, evidence about whether or not it works, the overall treatment structure. We'll cover a little bit about tic symptom tracking and selecting tics to target. And we'll spend some time working on functional behavior assessment related to this, as well as function-based interventions. All right, so our first one, what is comprehensive behavior intervention for tics? So the rationale for this type of an intervention is that there are multiple components that affect tics. So first, there's the external environment, and these things can increase or decrease tics. So especially things that are new, stimulating, anxiety provoking, all of these things can increase the risk of tics, as well as internal states. So feeling anxiety or excitement can also increase tics. And we know that we can't control the neurology of what's going on that contributes to tics, but we can teach people to control their internal and external environments and give them some more control over their tics. So how CBIT works, there are two main components of CBIT. So we have the behavior therapy, or those functional behavioral interventions. And in this one, we're figuring out what makes the tics worse and find ways to manage those situations. So it's really more about those external kinds of components that are increasing the risk of tics that we're controlling. The other main part is habit reversal. And so in this one, this is where we're really teaching people how to have more control over their tics. And again, CBIT is not a cure. It offers tools for people so that they can manage their tics more effectively and feel like they have a little bit more control over their life. All right, so it's always important to make sure that we're using evidence-based intervention. So I'm going to go over a little bit of the research about whether or not this is an effective intervention. So first, it meets the APA criteria for well-established interventions for tics. So this is pretty well established. This research was in 2007. It is also listed as the first-line treatment in Europe, who initiated this in 2011. Canada took on CBIT as first-line treatment in 2012, and the United States in 2013. But I think that this study is one of the most compelling pieces of evidence to support the effectiveness of CBIT. So in this one, there were 126 youth in the initial study, and 80 of them completed long-term follow-up 11 years later. So it's a really long longitudinal study about the impacts of CBIT. And you can see here that 67% of those who initially responded to CBIT demonstrated at least partial remission still 11 years later. And this is a program that you don't stay in forever. It's term limited with options for occasional boosters if you need it, but it's not ongoing therapy. So it's a time limited. And then 11 years later, 67% still demonstrated at least partial remission. And then the other group received supportive therapy, and 0 demonstrated at least partial remission. So really stunning, I think, impacts of this relatively cost-effective and non-invasive kind of intervention for people who have tics. So what are some treatment considerations? So when we're thinking about whether or not this is an effective or appropriate intervention for a specific client, we want to think about their age, their commitment to the intervention, comorbidities, and your experiences as a clinician. So generally, this intervention is intended for individuals ages 9 and older. So kids who are younger than 9 tend to struggle to identify their premonitory urges and commit to the work. So it's not a hard and fast rule. So there could be some children who are younger who are really committed and able to do the work. But generally speaking, 9 is about the limit for this intervention. And the same is true for individuals with lower intellectual functioning. So people who have lower intellectual functioning often really struggle to identify physiologically those premonitory urges, which makes it a little bit more challenging to implement this intervention. Another really important one is making sure that both the client and the parent, if you're working with children, are really committed to this intervention. So it takes an investment of time. You really need to set aside time to work on the tasks, and it's hard work. So we need to make sure that they really are willing and able at this time to invest the effort. If they're not, it's probably not going to be an effective intervention. So this is an important piece at the very beginning to make sure that it's a good fit for the client and their parent if it's a child. There are also comorbidity considerations. So there's a really high rate of comorbidity with Tourette syndrome, like most disorders in the DSM. And the ones that are most commonly comorbid with Tourette's are ADHD and OCD. So if you have somebody who has ADHD as well as Tourette syndrome, you need to think about how ADHD symptoms can negatively impact their engagement with treatment if they're not being managed. So pay attention to whether or not they can engage in the work with their ADHD symptoms. Some things you might want to consider to modify it if they're kind of managed, but still an impact would be to have shorter, more frequent sessions, have additional parent support sessions to help them help their children engage more effectively. During treatment, minimize distractors, and then use extra reinforcers to support them in helping them to manage those ADHD symptoms and engage in the work of CBIT. It's also really important to, in those initial sessions, differentiate between tics and obsessions or compulsions if the person has OCD as well. So the general way to think about this is that for people with OCD, those obsessions and compulsions really are related to specific cognitions about something bad happening if they don't engage in the behavior that causes that physiological arousal or the anxiety that makes them then engage in the compulsion. Tics are different because they don't have those specific cognitions. They're not really worried that something bad will happen. They have this vague sensory discomfort that things just don't feel right inside their body. And that's why they need to do the tic behavior. So really focusing on those differences are important because the treatments are different. If it is an obsession and compulsion, you need to work through exposure prevention therapy instead of CBIT for those. And so since it's possible for people to have both OCD and Tourette's, really looking at each individual tic-like behavior to see if it's a tic where you should do the CBIT protocol with it, or if that one is an obsession and compulsion that would require more of that exposure prevention therapy. Some other comorbidity considerations are developmental disabilities. So if you have these, as I said, they're a little bit more likely to have trouble recognizing those premonitory urges. So for these, if you decide to do some work with CBIT for people with developmental disabilities, you often have to be more direct. You have to have more rule specificity. So people with developmental disabilities are more concrete. They often require a lot more trials. So when people are learning things, they often only require a couple of exposures to learn it, but people with developmental disabilities often require more of those exposures to learn new skills and information. And they sometimes, need those, the reinforcements need to be more concrete. So point systems may be less effective for people with developmental disabilities unless they're related to pictures or stickers or something that, again, is more concrete. For people who also have depression or anxiety, it's often important to treat the depression before CBIT if it's not secondary to the tics. And same with anxiety. So if depression and anxiety are secondary to the tic disorder, then perhaps CBIT first could be helpful. But if depression or anxiety are their primary, then it might be helpful to really start to support them in those areas and then have them go into CBIT. And the last one is anger. About 20 to 30% of kids with Tourette's have rage outbursts, which are sudden, intense, and they feel extreme remorse afterwards. And with these, you would provide typical supports that you would for children with anger. But that would probably have to go alongside CBIT to help them engage more. And then clinician pieces. So in order to actually use CBIT, you have to know the process and the principles of it. You have to be pretty familiar with Tourette's presentations and familiar with these comorbidities. So as clinicians, we all have to make sure that we are practicing in our scope of competence. So it's important that we think about these things before we start engaging in a new technique. Okay, so moving into the treatment structure and the core components of what CBIT is. So in this part, we're going to talk about the rationale for CBIT, the overall structure of the program, psychoeducation, how to create a TIC hierarchy, how to create an inconvenience review, and what the behavioral reward program can look like. So again, the overall structure, the core elements of CBIT are the habit reversal therapy, and we'll go into more detail on this part next time. But this will include increasing awareness of their tics, making sure that we pay attention to their premonitory urges. And I even reviewed this last night and I did not catch this error. That's the urges and not urger. And then choosing a competing response. We'll also spend a good bit of time today actually talking about functional behavior assessment and intervention. So again, controlling those environmental aspects that can increase tic intensity and severity. Some additional elements that are not core features but are supportive, helpful parts of CBIT include psychoeducation, relaxation training, relapse prevention, and attending to motivation, and using both rewards and inconvenience. There's some psychoeducation about CBIT and tics. So we've already talked some about the rationale. I'm not going to go into the diagnosis, but you really need to be aware of diagnosis and what constitutes a tic disorder. It can also be really helpful, especially to talk to kids about the phenomenology of Tourette's. And Doug Woods at the training used this example about a spaghetti colander to help kids understand what tics actually are. So he really used the colander to represent the basal ganglia. And the colander or the basal ganglia's role is to let out appropriate behaviors and to keep inappropriate behaviors from getting through. And so with people with Tourette's, it's almost like some of those holes in the colander are too big. And so occasionally pieces of spaghetti, which are those tic behaviors, slip through, and that's what causes the tics, because those holes are just a little bit too big and not correctly holding everything in. It's also important to talk about the natural history of tics, and we'll go over that on the next slide. talk about those social difficulties and comorbidities. So like, how can this impact you, especially as, a middle school kid, if you're ticking in the middle of math class? Talk about the genetics and neurobiological bases and the prevalence of tic disorder. So we're not going to go into detail on all of these pieces, but these are things that you would cover in the psychoeducation piece of the CBIT protocol. So the general course is that Tourette's usually starts between ages 6 and 9. It's often the worst between ages 8 and 12, which is kind of cruel, right? This is right when kids are starting to enter adolescence and really worried about what everybody's thinking about them and having inaccurate perceptions that everybody is always staring at them, which makes it, I think, a little bit more uncomfortable for kids at that age. And generally, there's improvement into adulthood. So usually that really intense time of 8 to 12 lessens by the time people reach adulthood, even if they still are really struggling with tics. So generally by adulthood, about a third of people have very reduced, almost resolved tics. About a third, they've lessened in severity, but still deal with tics. And about a third, their tic challenges remain about the same. So one of the things that you'll do early in the process is make a tic hierarchy. So you begin with the tics listed during the assessment. So if you do the SciBox or something like that, as well as clinical interviews, you've listed all the tics that this individual has. And then as you go along, you're going to continue to ask about tics because new tics can arise throughout the process. So you want to make sure that this list is complete. So you need to make sure that you are frequently checking in and adding tics as necessary. So you also rate the severity on the subjective units of distress scale. So often for younger kids, they use the faces like I have here. For older kids, adults, we often just use the subjective units of distress scale from 1 to 10, but really making sure that you're identifying which tics are the most bothersome and which tics are less bothersome. And this is one of the things that you use to determine effectiveness of the CBIT program and when maybe you need to pick a different competing response for a specific tic. So again, you'll use this tic hierarchy to choose the order of tics that you're going to address. So often we start with the most severe, but sometimes we want to start with something that's easier because sometimes the more severe ones are more complicated. So we want to make sure that the individual understands the process and feels some success. So even though tic 3 might be the worst that they're having, in order to address that, they might need to gain some more skills and competence in identifying their tics and when they're happening and choosing a competing response. So we might want to pick an easier one first and then work our way up to the one that's the most bothersome for them. So we'll readdress the tic hierarchy every single week so that we can see how things are going, do the SUDs for every single tic that's on there. So like, how bad was this for you this week? And use that information. And again, we'll change that every week and use it as a progress monitoring about how things are going for each of the tics. Another thing that we do is complete an inconvenience review. So this one, you have the patients list everything they hate about the tics, all of the ways that it interferes with their life, makes their life hard. And one of the reasons we do this is to use it as a motivator. Because as I've said, CBIT is hard work. And so, especially for kids, they are often inconsistent in their motivation to do hard work. So this is one of the things that we bring them back to help them kind of recenter themselves about why they wanted to engage in this work. And we also have a behavioral reward program. So again, the rationale of this is to motivate by rewarding effort, not success. So let's say a kid engages in a new competing response and it completely bombs out, but they worked really hard. We really want to reward that effort, the working hard, even if it's not successful. So eventually we want them to be successful, but the rewards that we're giving them are for the work that they're putting into this process. So some of the points that we give them are for attending sessions, participating in sessions in the hard work, like while you're together, and then completing that homework. So doing the hard work between sessions, which is the most important part of the process, because that hour that you're working with the kid or the adult on this is really just giving them the skills to do the work in their real life, which is where they're practicing it with their homework. Okay, so now we're going to move into behavioral assessment and intervention. So in this, the first part we do is we do a functional assessment, and then we'll develop interventions, and then we'll develop a plan for implementing those interventions. So one of the first parts is we determine the factors that can make tics worse. So one of the things that can make things worse, the tics worse, are people. So maybe somebody's more likely to tic around their siblings, around certain teachers, around strangers. So making a list about the kinds of people where the tics are worse. The next one is places. So different places can also increase tics. So school, even specific classes, or the cafeteria could be places that increase tics, or sports practice, or being in the car. Another one is different demands. So having to do a specific chore, doing work in a specific class, those things can all increase different tics. And then situations. So sometimes tics are worse right after school, or in specific social situations, or when they're getting ready to go on vacation, something super exciting. And so you get this information through a very thorough interview with parents and the child. And also there are tools that you can use, like worksheets, to really guide getting this detailed information using functional behavior assessment tools. So when we think again about this functional behavior assessment, we really need to think about this whole picture about the tics and about what's happening before and what's happening after the tics. So what's happening before the tics happen are called antecedents. And those are some of those things we just talked about, those places, those situations, people, activities, internal experiences. And these are things that we can control. We can make some changes about what's going on in these. And when we can't make changes about where they are, we can give them tools about how to manage what's going on. Then we have the tic component, which we can't control, right? So people with tic disorders have this physiological and neurobiological basis of this behavior, which we really don't have a lot of ways to change. Then we have the consequences. So these are the things that happen after the tics occur. And these things can either reinforce. And so if we think about reward and punishment, or reward and escape, in behavioral terms, it's different from often how we talk about it in everyday life. So in reinforcement, it's anything that makes the behavior more likely. So in this case, anything that makes the tics more likely to happen. And positive reinforcement is a reward from having it happen. And negative reinforcement is escaping something uncomfortable by doing it. And then punishment in this case isn't necessarily like an adult giving a punishment, but it's anything that reduces the likelihood of the behavior occurring again in the future. We're going to use a story to kind of put this in perspective about how we can think about the antecedents and the consequences for a specific kid. So this is Billy's story, and this scenario comes straight from the Managing Tourette Syndrome Guide. All right, so we're going to think about our kid, Billy. He comes home from school. School's really stressful. He works really, really hard to control his tics while he's at school. So when he comes home, he's exhausted and he's stressed out and he's anxious. So like many kids, he goes to watch TV. He just wants to chill out and get away from this stress experience. But his sister is also in there. And so he's in there watching TV and kind of letting his tics go. His sister, as siblings often do, get pretty annoyed with him because it's bothering her watching TV. So she starts teasing him about his tics. Mom comes in Mom intervenes, mom sends sister out. She's like, that is not okay. We don't tease people. She comforts Billy about his sister teasing him, tells him that it's okay. He can watch whatever he wants to watch all the way till dinner. So since this has been the process of what happens for him when he gets home from school, he really tics a lot more after school than he used to, especially if he's watching TV and especially if his sister's there. So let's break this down now and look at what was happening here. So the first part, these antecedents. So he comes home and the antecedents are, so the things that happen before the tics, he's stressed out. So that's his internal state. He's anxious, another internal state. After school situation with his sister, person, watching television, situation, and whatever the room, the family TV is, would be the location. So all of those different components are the antecedents. When these things are happening, it is much more likely that he is going to be having tics. Then his consequence part, for the reinforcement, the positive reinforcement, his sister teases him. And so this might sound counterintuitive because when we think about positive reinforcement, we often think about something good happening. But again, it's about what makes the behavior more likely. So when his sister teases him, it's uncomfortable, but it actually does increase his tics. Another one is that his mom comforts him. So after this one, his mom comforts him. And again, it's not necessarily that he is engaging in tic behaviors to get his mom to comfort him, but it does end up reinforcing that behavior. He gets to watch anything he wants until dinner. So all of those things are positive reinforcements. They increase the likelihood that he's going to engage in tic behaviors. Negative reinforcement is his sister is sent away. So that uncomfortable bad experience of his sister teasing him stops. And that's what negative reinforcement is. And in this situation, there aren't any punishments, even in the more lay terms that we think about it, but more importantly, in that there's nothing that happens here that decreases the likelihood of his tics. And again, it really is important for us to really highlight that Billy is not manipulating this situation in order to get the comfort or in order to get his sister sent away or to get to watch whatever he wants till dinner. He probably doesn't even realize that this is happening. But if we think about this in behavioral terms, those things are being positively and negatively reinforced. All right, so let's think again more intently about examples of antecedents that can affect tics. So again, those emotional states, and these can be uncomfortable, like being upset, stressed out, or anxious, but they can also be really good things like being excited that you're going to Disney World tomorrow. So it's not only negative ones, but it's the valence. So the intensity of those emotional states can increase tics. Activities, being alone, being in groups, watching TV, talking about tics, stressful events. So these can be pretty individualized. So pretty much any activity that for that person increases their likelihood to engage in tics would be an antecedent. Some examples of consequences that can affect tics. So the things that can increase them are adult reactions. So things like comforting or giving them attention can increase tics. Another one is escape. So getting to leave the classroom, getting out of the task, and peer attention. And again, peer attention, either positive or negative, can increase tics. Some things that we can think about that can decrease tics is making sure that we are trying to avoid things like teasing or embarrassment, increase opportunities for positive participation, and avoid providing escapes from unpleasant tasks can all help us to decrease the consequences of tics. So I also want to highlight that tics themselves are a negative reinforcement. So that premonitory urge, that tickly, itchy, uncomfortable feeling that people get is not pleasant. And the tic then provides relief. So it takes away that uncomfortable feeling, at least for a little bit, so it negatively reinforces engaging in that tic. So every time they feel that urge, they are like, I know that last time I ticked, and people aren't consciously thinking this, but their body goes, last time I engaged in that tick, that icky feeling went away for a little bit. And so that negatively reinforces it and increases the likelihood of tick behavior in the future. So when we get to the part where we talk about competing responses, engaging in the in that competing response when they get that premonitory urge takes away that negative reinforcement cycle and disrupts that motor pattern, which then gives people more control over their tick behaviors. So when we think about dysfunctional behavior interventions, again, we're helping to control the environment to manage the tics. So we want to remove those reinforcing consequences. So again, with Billy, we want to make sure that he's not getting comfort at that time. We want to make sure that he's not getting to watch what he wants that whole time. We also want to minimize or avoid antecedent or exacerbating situations. And then when these situations are unavoidable, because they are sometimes, we'll take scheduled breaks when possible. And that is the perfect time to practice habit reversal as well, or those relaxation techniques to manage the anxiety. Another part about controlling the environment is educating teachers and especially peers or siblings about tics so they understand why the student is engaging in these types of behaviors. So if we think about what function-based interventions could look like for Billy, so to manage his anxiety, we can teach him some relaxation strategies so that he knows when he's having these feelings, he has some things to do that he can calm down his nervous system and feel a little bit better. We can change what happens when he gets home from school. So right now he's watching TV in the den with his sister. So we can change the setting, we can change the activity, and we can change the person. And probably changing all three of them would be the most effective in kind of removing him from those antecedents that are increasing his tick behaviors. Some consequence reinforcers. So right now his sister teases, and our antecedent would address that. So if we have him not be in the den watching TV with his sister, right, that removes that sister teasing him. Comforting him after the tick behavior is not helpful because it reinforces the tics. But with this, we want to make it clear that we're not saying that parents should not comfort their kids. So definitely remember, Billy needs some comfort, but remove it from the tick behavior. So maybe wait 10 or 15 minutes and definitely make sure that we're giving love and comfort and making our kids feel good, but not right after tick behavior, because then that ends up reinforcing the tick behavior. So right now, Billy gets to watch TV and watch whatever he wants all the way till dinner. So maybe instead of watching TV when he gets home, he should use this time to practice his tick management and watch TV at another time. The other one with the negative reinforcement is that the sister stays away. So maybe times when she does tease, because they are siblings and it probably will happen sometimes, is that maybe she should apologize and stay, because then he's not getting reinforced by sister being sent away. Because lots of kids, even if they don't admit it, sometimes like to see their siblings punished because of sibling rivalry and the kinds of relationships that siblings can have. All right, so some other examples of interventions for antecedents are, so bedtime is a common time when tics are frequent. So having good, relaxing bedtime routines and using this time to practice relaxation can be helpful. Car rides. So first is to make sure that you decrease any safety risks. So put on child locks, maybe have the child sit in the middle seat. Scheduled car rides during low tick times when you can, and when you have to be in the car other times, practice competing responses while in the car. Classrooms are a common place for tics too. So one thing that we can do is have preferred seating. This doesn't have a specific place, so it will be different for different classrooms and different students, but making sure that they're in a place where maybe their tics are a little bit less noticeable. After school, you may be having 15 minutes of downtime before any demands to kind of de-stress before they dig into work. And watching TV can also be a trigger for a tic. So maybe limit TV watching time or watching TV during low tic times when possible. So some examples of consequence intervention. So for social attention, one is don't just tell the patient not to tic. If that worked, they wouldn't need to come see you for support, because I can guarantee you that everybody's thought about it if they haven't already told them not to, or the patients themselves have said, don't tic, don't tic, don't tic. So just saying not to do it really isn't helpful. Don't comfort the patient during tics. So again, comfort is important, but it needs to be separated from the tic behavior. Don't laugh at the patient and encourage peers not to react to tics. So just ignore them when they're happening. For the escape part, don't ask the patient to leave. So sometimes kids would, when teachers are trying to be generous and kind to students, would let them leave the classroom and maybe even get out of doing that task. So that's going to increase tic behavior. So they still have to do their math homework, right? So maybe they have some extra time, or then maybe they can do it someplace else, but they still need to do that work. During times when the tics are bad, remind them to use their competing response. So for example, at bedtime, when tics are bad, they have to stay in their room, so they don't get to get out of going to bed because they're having tics. This would be a time to practice those strategies for themselves. Right, so after you identify what interventions you're going to use, you need to develop a plan for that implementation. So discuss with the parents or the patient themselves, if they're an adult, when and how the intervention will be implemented. So people have busy, busy lives. And if you don't make a specific plan for when and how you're going to do it, it's so easy to just drop them and not get them done at all. So we can't just say, yep, sometime during this week, do this stuff. We really have to help them make a plan to schedule when and how they're going to do it. And these things usually don't go off without a hitch. So think ahead about potential challenges, like what could get in the way of being successful with this, and make preventative plans to deal with those to increase the chance that you'll implement the intervention and find some success. And then provide any training support as necessary for parents or adult patients to implement the intervention. So sometimes when people don't implement the intervention, it's because they actually were missing some skills. So this is important to revisit. So the next time when you meet, how did the intervention go? Make it a safe place to say the intervention didn't go well, or I actually didn't do it. So then you can address what's going on and identify those places where parents or individual need some extra support and skills so that they have what they need to implement the intervention. So relaxation techniques are not part of the habit reversal or competing response, but they are part of the overall protocol because they can be used to help manage anxiety. So we'll talk a little bit more about this next session, but some of the things that are involved in this are probably pretty familiar to you if you work with people with anxiety, are things like diaphragmatic breathing and progressive muscle relaxation. And again, these are part of those managing what's going on in the environment. So then we're going to have an overview of habit reversal training to end today. And then next time we'll go more depth into what habit reversal training is. So again, the first component of this is awareness training. So in this, we're really just trying to get people to pay attention to their tics. And the rationale for doing this is that we can't change behaviors if we don't know they're happening. So through this process, we're going to have the patient start to self-monitor. We're going to have response description. So what's going on in your body? What kind of behaviors do your tics entail? Response detection. So being able to go, oh, I'm ticking right now. And then early warning, or to be aware of those premonitory urge that I'm about to tic. So the self-monitoring is a very necessary part, but not sufficient. So it's the first stage. And in this, we're going to start to look at the frequency, the days and times when they're more likely to happen, and the situation. So again, understanding the tics for this individual. So on this, again, we want them to pay attention to their tics because we want them to know when they're happening and how frequently they're happening. And sometimes people are actually unaware that they are ticking. So sometimes the clinician during sessions will have to ask them, did you know that you were ticking right now? Because sometimes they're not even aware of it. And a really important caveat for this is that this process can make it feel like the tics are getting worse because they're paying more attention to them. So research suggests that they actually aren't getting worse, but when we pay attention to them, it feels like they are. Similar to like when you buy a new car and then all of a sudden that make and model, you see it everywhere. So you just have this heightened awareness of it and it makes it feel like they're getting worse. So warning people that it's going to feel this way will help to mitigate some of the anxiety and feeling like, ooh, maybe this intervention isn't for me because it's just making everything worse. The next part is response detection. So in this one, you have the patients define the tic in general, like all the body parts that are involved, knowing that some of them are actually quite far away from the initial tic, the order of the movements, and then that premonitory urge, those sensations or tic signals. And it's really important to identify all components of the movements because sometimes the very first one is subtle and not something that maybe the clinician will see, but it is the part where they actually need to use the competing response. Because if we try to get the competing response further down in the chain of the tic behavior, it's not going to be as effective as if we get it right at the very beginning. So again, response detection. So sometimes it's to figure out all of these parts as a therapist in between sessions, maybe kind of doing the tic yourself and seeing what all is involved, because especially for kids, they don't always have a lot of skills to pay attention to all of those bodily sensations. And I would say just in general, we don't pay attention to those. So we need to teach people how to really pay attention to what's going on in their body. So during this time, then you just have a brief conversation with them about whatever's going on and you have them lift just a finger to acknowledge that they've engaged in a tic. So this is practicing their response detection, making sure they know when they're having tics. And also then patients can identify when they have the urge to tic. So first we get the response detection. So we want them to be pretty skilled at identifying when they're ticking. And when they've got that down pretty well, then we'd go on to being able to know when they're about to tic. So with this, it's really important that during these conversations, like that you're asking them about, you know, piano practice or what they're doing with their friends, that is just kind of the background. And you really have to be paying attention to their tics mostly, and just having that as a background conversation that feels kind of natural for the tics to occur. Then eventually we'll choose competing response. So there are 3 rules for a competing response. It has to be incompatible with the tic or make it harder to do. It has to be less noticeable than and less interfering in the tic. And it has to be something that you can do anywhere, even in the shower. So it's important that the patient picks this. It can be hard for kids sometimes, but they'll be more likely to do it if it's one that they've chosen. So they pick one, then you go through the criteria to see if it will work. And I found that with kids, oftentimes the first couple that they pick aren't going to be compatible. So sometimes you can help them tweak a tic that they, a competing response that they want so that it then does fit the 3 criteria. So the role of that social support or coach, so for kids, it typically is mom, but it can be another adult. We want to use this to reinforce and prompt the use of competing responses and to praise them when they are using the competing responses. So again, usually mom for kids, but it can be a spouse, a housemate, a sibling, some other adult for kids. This training should be encouraging and not punitive. So one example is that you're permitted 1 reminder per setting. So the support person can give 1 reminder per dinner. And if the kid is still struggling, you let it go. So it's not supposed to be another way for us to nag our kids, but a way to provide support. So an example about what you can say is, don't forget your exercise. So we have to remember too that this is the patient's treatment. So again, we need to give some autonomy and control even to those kids to make sure that they are taking ownership of their treatment. And again, we want to really praise the practice, not the success for this. So our reward program, as I said, CBIT is really hard work, and it's hard for kids to stay motivated to do hard work all of the time. So this is the reward program is supposed to help them with that process. So they get points for their effort, again, doing the homework, coming to sessions, working hard during sessions, and you have the parent and the child determine what the points can be turned in for. So these should probably have a variety. I think it helps to have things that are like really low value that they can be turned in quickly with 1 or 2 points to get something for reinforcement right away, or something they can save up for that's bigger. So it can be a mixture of monetary and non-monetary things. So staying up later, picking out a family movie, going out to eat or for ice cream, getting bottle stickers, all of those things are examples that can be rewards. And then you review those weekly, right? And again, encourage especially the children to keep working, even when things are getting hard. Okay, so next time then we will get into an overview of implementing the program, and there is some time for questions if anybody has any questions.
Great, thank you, Dr. Wilcox. While we're just waiting for the questions to come in, I'm just going to launch the post-webinar evaluation. So those of you that do want the Canadian Psychological Association, what are they? Sorry, completely forgotten. The credits, sorry, going out of my mind today. Yeah, so I'll just launch that and go back there.
Yeah, so I see one about some examples of competing responses. So for example, a lot of motor tics are with hands and arms, right? So if you lock your elbows straight down, you can't flick your arms around. So you would be able to do that in the shower, on the soccer field. You might look a little bit funny doing that one, but if you locked your arms, you wouldn't be able to flick it. Another one would be for vocal tics. A common one is to breathe with your mouth shut, right? So there are different ones. And in the book, there are a big list to get you started, and we'll talk more about competing responses next time. So the next one, I have not heard about CBIT being indicated for trichotillomania. I don't know. So there's a possibility, but I haven't looked into that one at all. Sorry. So for kids under 9, so I think one of the challenges too, whether or not the actual CBIT part works depends on if the tics are bothering people. So for some kids, they really don't care, right? And so if the tics are only bothering the parents and not the kids, it's not going to be super effective. But for people who aren't ready to do the competing responses, you can do the environmental part, so the functional behavior assessment and interventions. And so then just even controlling those antecedents and consequences can help a bit for people who the competing response part's not appropriate. Yeah, and so we will talk more about the habit reversal. So it's around those competing responses. So I gave an example of one competing response, and we'll get into more on the competing responses next time. All right, so what's the best way to delay comfort if there is rarely extended periods of time between tic episodes? Yeah, so I think that would be a little bit trickier. And I would say probably if the tics are that intense, that maybe, especially at the beginning, having medication in conjunction with CBIT might be helpful, and maybe then having those controlled a little bit would help give you some of those opportunities. So if it's a point where kids are never having a break from it, then I think it might be a little bit harder to not ever have comfort during those times. Yeah, so the OCD and tics, I think the biggest one is about what they think is going to happen. So typically with OCD, kids think that something bad is going to happen. Like, if I don't do this the right way, somebody in my family is going to die. If I don't do this the right way, yeah, then we're all going to get sick. So it's that bad thing happening that is one of the ways to distinguish between OCD and tics. So when it's a tic, you don't think that something bad's going to happen. You just want the feeling in your body to go away instead. That question's more for you, Julian.
Yes, I can do that. That's fine. I'm afraid the pre-session questionnaire can't be accessed now because it has to be done obviously before the webinar. So just respond to the email that I send out later and I'll sort it out with you. Don't worry.
Yeah, so question about the effectiveness of online or workbook style CBIT intervention. So CBIT is generally workbook based. So the books that I put at the beginning form the foundation for the process, and especially for kids, working through the workbook with the family can be very helpful. Yeah, and at my training, Doug Woods talked about the online versus face-to-face, and they've actually found that online is very effective. I'd say that the one that is less effective is group-based because of the transferability of tics. So doing CBIT with a group of people tends to not work very well, but doing CBIT online seems to work about as well as doing it face-to-face. Yeah, so if the tic is primarily concerns the parent, how can you ensure that you're targeting a tic rather than an autism stim? So that was really, I think, an important part of your diagnosis. So taking time to do a good diagnosis and making sure that you're ruling out competing possibilities and choosing the best diagnosis for that child would be the best way to do that.